Hi, I'm Dr. Patrick Foy, and this is a Facebook Live question and answer session all about coccyx pain or tailbone pain. I am the director of the Tailbone Pain Center here at Rutgers, New Jersey Medical School in the eastern United States. And today is Tailbone Pain Awareness Day. It is the second annual Tailbone Pain Awareness Day. It's November 15, 2019. Really, I'm taking this as an opportunity to bring attention to a medical condition that often is underdiagnosed and undertreated, and a lot of physicians and healthcare providers do not know all that much about coccyx pain. A lot of people suffer for many months and years, and in some cases decades, with this without being able to find answers to what's causing their pain or the best and most modern treatments that are available. So I've posted on the Facebook page for the Tailbone Pain Center, I've posted a request that people can submit their questions, and I have sort of been flooded with, I've copied a number of them here. I've been flooded with dozens and dozens and dozens of questions, more than I can probably get through in this one video session. Last year for Tailbone Pain Awareness Day, the question and answer session went on for more than an hour and a half. And even after that, there were still a lot of questions I needed to get to. Just that I do have a block of time now to go through this, but then I do have to get back to seeing more patients with tailbone pain a little later on this afternoon. So I see people are saying hello, and certainly welcome to all of you. A couple of housekeeping issues. Typically, if people are chiming in, greetings. I usually won't refer to you by name just because if the video goes into other formats or on YouTube or someplace else and later, just to respect your own privacy. Also, please remember that this is the internet. It is a public forum. So certainly I'm happy to answer questions for you and provide educational content. But do realize that things that you're posting online, there may be others. There are of course others that would be able to see your questions and your information. The other thing I'll point out is that for this session, I won't be giving specific medical advice. I won't be telling you that you specifically should do X, Y, and Z. Those would be things, of course, for you to discuss with your in-person treating physicians. But instead, it's really more of an opportunity to discuss the educational topics so that then you can take that information back to your healthcare providers. So I see folks on there are saying hello. Certainly greetings. Great to have many of you on there. I see people from around the world. I see someone from Illinois and Pakistan and other places. So terrific to have you all here. I'm going to start looking at a few of the questions here. In fact, what I'm going to do, I have 7 full pages of questions so far. So I'm going to have someone who's helping me here. I'll have you go through and perhaps if you can summarize kind of what's the key question out of what's there. And from Germany, greetings. Great to have you here as well. So I'll take a look at one of the questions here I see is about I wonder about pain that's returning after a removal and how could that be? Unfortunately, yes, there's many patients who, after a coccygectomy, which is surgical removal of the coccyx, which is really reserved for a very small percentage of patients overall who have tailbone pain, the vast majority will respond well to non-surgical treatment. But of the, maybe 1% or less of all patients with tailbone problems that do end up going for surgery, unfortunately, most of them will have some degree of pain or discomfort that persists despite the surgery. In terms of the question here, which is reasons for that, there's lots of reasons why that can happen. Sometimes there is scar tissue at the surgical site. Sometimes there's a retained bony fragment at the site of the surgery. Sometimes there's infection either of the soft tissue or infection of the bone, which is called osteomyelitis. For some of this, I will refer you to, if you go to my website, which is tailbonedoctor.com/ facebook.com/blog, blog. In the upper right-hand corner, there's a little search box there, and if you put in the word coccygectomy, it will take you to a bunch of articles that I have in there specifically about coccygectomy, and there's a number of them on there about pain after coccygectomy and some of the causes of that, so that can help to educate you about some of the things that can cause it and some of the tests that are typically done to look for that. I have inherited many patients in recent years in particular who, before they've ever seen me, have had coccygectomy and have had ongoing pain in that area. And I've had patients, of course, of my own who have referred for coccygectomy. Not everyone responds to non-surgical treatment, although fortunately the vast majority do. But of those who I've sent on, some of them have done extremely well, and some of them, unfortunately, do have some ongoing pain in that area. Other questions I'm going to have?
All right, so a patient had coccygectomy.
Loud enough just so that they can hear you.
All
Thanks.
Right, sounds good. So a patient had a coccygectomy about 4 years ago and now was diagnosed with permanent pudendal nerve pain. They're wondering, they still have the pain in the area. Could it be scar tissue or something else?
Sure. So the question is about pudendal nerve pain in a patient who has undergone coccygectomy or tailbone removal surgery or amputation of the coccyx or tailbone. So the nerve fibers for the pudendal nerve come off higher in the spine. They come off in the sacrum. So in the anatomic model that I'm holding up, right now, this part of the spine up here is called the sacrum, and then down here is the coccyx or tailbone. And the area of the coccyx, by the time we get down to that lower area of the spine, the nerves for the pudendal nerve have already come off higher up. It comes off at sacral levels 2, 3, and 4. So the issues and the surgeries and problems down at the coccyx typically do not directly cause a problem with the pudendal nerve. And pudendal nerve pain, by the way, is often called pudendal neuralgia, or you'll see clinicians will often abbreviate it as PN for pudendal neuralgia. And along those lines, so the surgery at the coccyx or the coccyx problem itself would be unlikely to directly cause pudendal neuralgia. However, one of the things that starts to happen when people have tailbone pain is that they start to sit in an abnormal way. So, for example, I'll show you here just with this anatomic model. If the person is sitting, while they're sitting, I'm not sure how much of this is showing in the camera here. While they're sitting, the tailbone can start to make contact with the back of the seat. It's perhaps better to show it on this model. The tailbone can make contact with the back of the seat. If they sit leaning to the side, to either side, then the tailbone is no longer making as much direct contact with the chair that you're sitting on, and that often means that the patient will have less pain. But if you're sitting leaning more towards one side than the other for prolonged periods of time throughout the day, week after week, month after month, often what will start to happen is that people will get other pelvic pain syndromes. They'll start to get pain in their piriformis muscle or their sacroiliac joint. Other areas can start to spasm up, including within the distribution of that pudendal nerve. One of the things that can be done for the pudendal nerve is to do a pudendal nerve diagnostic or test injection to put local anesthetic at that nerve and see if that helps to relieve the pain, and it can help you to decide whether it makes sense to do an anti-inflammatory injection for that nerve. And in a very small percentage of patients that may actually need surgical release for that nerve to relieve some of the pressure on it. So, okay, I see another question popping up here. What I'm going to do for the questions, I'll try to take the ones that are online for people that are right with us now, and then I'll come back to the other ones that people have submitted in advance. So if they're not online at the moment, I'll try to come back to those later on, if not within this same one session, sometime during the rest of the day today or this weekend. Somebody has constant pain near the tailbone for 5 years. Yes, this certainly can be very chronic. What particular exact type of MRI do you recommend? This is a fantastic question because one of the things we see is that it is very, very common that when patients have an MRI done of the tailbone, that it actually does not include the tailbone. For example, it is very common that people will have the imaging studies done of the lumbosacral spine instead of the coccyx. Part of the problem is that low back pain in the lumbar region, up around the belt line, is probably 10 to 20,000 times more common than tailbone pain. Really then what happens is that the medical establishment is kind of on autopilot for treating patients with low back pain. If you go in to see your doctor, you say, hey, I've got some pain down there somewhere. Hopefully, the physician is doing a careful history and a thorough physical examination to figure out exactly where your pain is coming from. However, unfortunately, that does not always happen. And often what happens is it gets labeled as, sort of generic low back pain, and the doctor will sometimes order x-rays or MRI, and they'll just check off the standardized box for, lumbosacral x-rays or lumbosacral MRI or lumbosacral CT scan. And then what happens is that the imaging studies are done in such a way that it includes the lumbar spine and just the upper part of the sacrum, but it does not go down low enough to see or include the coccyx. And this happens, I would say, pretty much every day. I have patients who are traveling in to see me. About a third of our patients here fly in for treatment here at the Tailbone Pain Center, and they bring stacks and stacks of CD images that they've had done previously. And we take the time to go through those and look at what's been done. And it's very, very common that the previous MRIs and x-rays did not even include the coccyx at all. Patients are often shocked because they've been told, hey, we did the imaging studies and everything was normal, when really it did not even include the symptomatic area. For more details on this, again, if you go to my website, tailbonedoctor.com/blog, B-L-O-G, and in that search box in the upper right-hand corner, just put in the letters MRI, and it will pull up some articles on that will tell you the appropriate MRI. It needs to be done basically lower down at the sacrum and coccyx, and it needs to include what are called midline sagittal views, which are slices that go through the midline, almost like slicing a person into a right half and a left half, right down the middle. And that's done typically in T1 and T2 if it's requested. If it's not requested, then the standard routine slices for a pelvic MRI will not include the coccyx, and the standard routine slices for a lumbosacral MRI won't go down low enough to include the coccyx. So it's very, very important that the ordering physician specify those particular things so that the radiology technician knows the appropriate testing to do. So great question. Thank you. Other questions that have come up in the feed. Let's see if I can read some of these. Let's see if the tailbone wouldn't show something shown up if a correct MRI. I think that's kind of asking the same thing about, well, was the correct MRI done in the first place? And really for that, what I recommend is that people, number one, get a copy of your radiology reports and take a look at them yourself. Again, patients are shocked when they fly in to see me and they've been told that everything on the previous imaging studies were normal. And I have a yellow highlighter rule that I tell people to use, which is take a yellow highlighter, get your report, highlight that it's the correct name, the date, and any place on there where it refers to the coccyx or tailbone, highlight it. And people are shocked when they realize that the radiologist never made any mention at all about the appearance of their tailbone or coccyx, even though that was the exact reason why they went in to have the study done in the first place. That can be starting point number one, is to look at the radiology report and see, did the radiologist actually address the area where you're having your problems? And it would be shocking to many of you how frequently, unfortunately, the issue is just not mentioned at all. So it was totally missed. Maybe the radiologist didn't even realize that that's why the study was being done. And then number two is to take a look at the actual images. So in the old days, we used to use, the X-ray view box, to put the films up. Nowadays, most of those are on CDs. But really, I recommend that people ask your treating physician to, bring up the images and point out the tailbone to you. And I get emails from around the world from patients who say that they read that that bit of advice in my book on tailbone pain, and they talked to their treating physician and they said, "Holy cow, that MRI or CT scan or X-ray that was done 2 or 3 years ago that we were told by the radiology report that everything looked fine, that instead when they actually go to look at the images and try to have the physician point to the coccyx, that it's not included at all, that the tailbone is not on any of the images. Obviously, that's one way to double check. Number one, that your physician hopefully knows how and where to identify the coccyx on the imaging studies. But number two, that you may see some abnormalities that the radiologist missed or did not pay attention to, frankly. Are there other questions that are posted online already?
So somebody was asking about synovial cysts.
So yes, I think I saw that. So a question about synovial cysts. So cysts can happen. There's lots of different types of. There's a number of different types of cysts that can occur. In general, a cyst is a fluid-filled sac. So think about something like a tiny water balloon. And in the area of the sacrum and coccyx, there's a couple of different types of things that can happen. Perhaps most common, or that people may have heard of, is a pilonidal cyst, and basically this is a cyst it often occurs in the sacrum and coccyx area beneath the skin, and it can become infected or inflamed and swollen and can cause a lot of pain in that area, and then sometimes it'll sort of burst or pop open and there'll be oozing. In fact, for that, again, if you go to tailbonedoctor.com/blog and put in cyst, C-Y-S-T, in that search box, it will pull up some articles on that for you. And basically then, for the other thing that you can have is a synovial cyst, which is basically the synovium is the fluid within a joint. So within all of our joints, we have our synovial joints, they're called because they have this synovial fluid in there. So think about a little bit of a lining around it, and then the fluid is inside. And a cyst can be when there's inflammation or swelling of that fluid. And that can happen in a number of joints and areas throughout the body. It can certainly happen at the coccyx as well, although far, far less common. But it would be something that would show up typically on the MRI, particularly in what's called the T2 sort of filter setting for the type of images there. So inflammation can be seen, and then sometimes that may be an indication that if that area matches where the patient is having their pain or symptoms on physical examination, that it might be worthwhile to put some local anti-inflammatory at that area, which can be done by a small local injection, typically done under guidance of fluoroscopy, which is kind of like X-ray up on a computer screen.
Okay. All right, next we have someone wondering can the bones of the coccyx fuse together, and what would be the reasons for their fusion?
Sure. So the question is, can the bones of the coccyx fuse together, and if so, why? So yes, there's a lot of variability at the coccyx in terms of how many bones are present. It's usually anywhere between 3 and 5, so 3, 4, or 5 individual coccygeal vertebral body bones in that area. I'll try to hold this up to the camera if I can. So sometimes these are totally fused together, so that the entire coccyx is fused to the sacrum, and all of the coccygeal bones are fused to each other, sort of as shown on this anatomic model here. But that's certainly not the most common pattern, although certainly I've seen many patients with that. Much more common is that some of the joints are fused and some of the joints are not fused. So there's a lot of variability there. And a lot of times that can be lifelong. So the patient may have some joints that are fused and some that are patent. And then, the issue starts to become, are they symptomatic or not? If the coccyx is fused, the problem there is that the coccyx then does not have the normal flexibility to sort of move out of the way. So when we sit and put some pressure onto that area, that pressure can, from the chair, can sort of help the tailbone to flex forward a little bit and tuck itself into the pelvis so it's out of the way. If the coccyx is fused and fixed in its position, then it's not able to do that, and it may therefore be causing more pressure onto the tailbone when you're sitting. So that's one of the issues. Sometimes after a trauma or fracture, at a fracture site, the way that we heal a fracture is by building new bone to try to repair the bone that's been fractured. And that can that new bone or callus formation can sometimes bridge across the joint space and cause a fusion as well. One other thing that I'll mention, just while I'm thinking about it, today for Tailbone Pain Awareness Day, if you do not already have a copy of my book, Tailbone Pain Relief Now, that is available completely free on Amazon. It is 272 pages. It is basically all information about the coccyx. The first half of the book is all about treatment of tailbone pain. The second half is all about, the first half is all about evaluation and testing and diagnoses, and the second half is all about treatment. And you can get it on Amazon for free today, which is Friday, November 15, 2019. I may be able to extend that through the weekend. I'm not sure. So whenever you're listening to the video, if you go to Amazon in whatever part of the world you are, and if you just put in, if you put in tailbone and my last name, which is Foy, which is F as in Frank, O-Y-E. It will pull that up. It's the ebook version. So it'll show you both the paperback version, but also if you click to show other versions or editions, it will show you the ebook version, which is completely free for anybody who wants it. Last year, hundreds of people for Tailbone Pain Awareness Day took the opportunity to get the book for free, which is fantastic. Here at Rutgers, New Jersey Medical School, we're all about educating people about their healthcare conditions so that they can get the best care possible and have make the most informed decisions with their in-person treating physicians. So, other questions?
Next, we have, why is it so hard to find a facility to do dynamic x-rays?
So, great question. Why is it so hard to find a facility to do dynamic x-rays? So let me explain what the dynamic x-rays are. By dynamic x-rays, really this is x-rays that are done while the patient is sitting and comparing those with the x-rays that are done while the person is standing. And this is hugely important. This idea to do the x-rays this way was a brilliant idea. I wish I could say it was my own, but it was actually of a dear colleague of mine in Paris, France, Dr. Jean-Yves Maine. And Dr. Maine had the idea a couple of decades ago to say, well, since patients have their tailbone pain while they're sitting, and for some of them, their x-rays the standard x-rays are done while they're standing or laying down, which is a position that's not putting direct pressure onto the tailbone. So his idea was, well, what if I took the x-ray while the person is sitting down? And I can show you in here, there is a chapter on that, that basically what is done, I'll hold up the image here to show the general idea, which is while the person is sitting down, they're putting their body weight onto the tailbone, and then that side view or lateral view can show what happens when the person puts their body weight onto that area. So basically here, if you think about, you can see that as the person would be sitting and putting their body weight onto that area, they're going to put pressure on the coccyx, and if there's some joints there that are unstable because of torn or stretched ligaments, then they may go into a dislocation or abnormal movements that can be seen on the sitting x-rays. That's the general idea of the sitting versus standing x-rays. The reason why this is crucially important is that hypermobility, excessive movement of the joints at the tailbone, are the most common cause of tailbone pain. So basically, you can see instances like this where, as in the image I'm showing here, where the coccyx looks totally normal when the right here when the patient is standing up or laying down. But then over here, when the person is sitting, they may have a dramatic positive dislocation. Hypermobility or abnormal movement, is again, this is in chapter 6 of the book. Unstable tailbone joints or dynamic instability. In the section of the book on causes of tailbone pain, the reason why this is the very first chapter is that this is the most common cause of tailbone pain. And it is extremely unfortunate then that almost no radiology centers or hospitals are familiar with how to do the sitting versus standing x-rays. And that's unfortunately because then the diagnosis gets missed. People get told that their x-rays are normal, that there's nothing wrong with them. Sometimes doctors or others can become dismissive and say, well, there's nothing really wrong with you. Maybe it's all in your head. You should just try to meditate or have some herbal tea or something. And nothing wrong with meditating or having herbal tea, but much better if you have an unstable coccyx to have that appropriately diagnosed and treated. So back to the question, which is, it really just hasn't caught on, partly because of tailbone problems being dramatically less common than the problems in the lumbosacral spine and throughout the rest of the spine. Problems at the tailbone pain, again, probably 10 to 20,000 times less common than problems in the low back or lumbar or lumbosacral region. So how much does it really make sense for the typical doctor or radiology center to start to put in a lot of time and effort in figuring out the best way to do these studies if they're not going to see another patient with tailbone pain until they see, 20,000 other patients with low back problems and other things that they're already familiar with evaluating and treating. So unfortunately, that becomes part of the problem along these lines for getting imaging studies to do these. It is very common that people will say that they asked for them at their local radiology center and they were told that there is no such thing, which of course is definitely not true. This has been published in the literature for a couple of decades now, and it's really just a matter, unfortunately, of coccyx problems being rare enough that people don't know how to do them properly. We've had a few thousand patients who we've treated for tailbone pain here at the Tailbone Pain Center. Almost all of them have the sitting versus standing x-rays done. And I would say out of all diagnostic testing, hands down, the sitting versus standing x-rays are the cornerstone of making the diagnosis in a majority of patients.
Okay, next we have a patient who fell about 5 years ago and they're having internal manipulations done, but it's not really helping and the coccyx doesn't stay in place.
Got it. So the question is, somebody who had a fall 5 years ago, ongoing tailbone pain for all of this time, and the manipulation injection or manipulations that they're having done rather have not been giving relief or sustained benefit. The real question comes first to, well, what is the specific diagnosis? So for example, if the coccyx is hypermobile, if there's excessive mobility of the tailbone, then of course you're not surprised that manipulation may not be the most effective treatment. Manipulation, depending on what's meant by manipulation, sometimes people just refer to that as sort of any internal approaches that are done at the tailbone, or external as well. It's basically applying a mechanical physical force either from internally or externally at that area. And basically, the issue starts to be that if it's the most common cause of tailbone pain, which is that they have hypermobility, excessive movement, and if by manipulation, what's meant is that the physician or the chiropractor or doctor or pelvic floor therapist is basically going to put one or two fingers inside the anus. I'll show you here from again an image from the book, and the thumb typically on the outside. That manipulating the coccyx, if they're trying to mobilize it, and it's already too mobile to begin with, then that may be one reason why the manipulation, is really not, may not be the answer for a specific patient. So really it comes down to making a specific diagnosis first to figure out what treatment is likely to be the most helpful. But I would say that's probably the most common reason for why the manipulation may not be working, is that the coccyx may already be hypermobile to begin with. And even if you move it into its quote-unquote normal or neutral position, if the ligaments are torn, then there's nothing really to help to hold it in that position.
Next person is wondering if there's two types of surgeries, one that preserves the ostium, the other that does not, and what will be the advantages versus the risks.
Sure. So the question is about the surgery, so coccygectomy, which is surgical amputation or removal of the coccyx or tailbone, and the question is about whether to preserve the periosteum. So the periosteum is the layer around the edge of the bone. And it's an attachment site for a number of muscles and tendons, ligaments of the pelvic floor. So the idea of preserving or leaving the periosteum in place is number one, that theoretically you're leaving the attachments of the pelvic floor still attached to the periosteum in that area. And theoretically that might give you less likelihood of a pelvic floor prolapse or sagging of the pelvic floor after the surgery is done. So that would be one idea about leaving it in place. Theoretically, there may be a little less likelihood of infection, although again, some of the verdict is out. Some of these are more theoretical than large studies done to look at one way versus the other in sort of classic randomized trials, which becomes a problem with coccyx problems in general, which is because the problems at the tailbone are less common than what we see in other areas. It's not like treating something like high blood pressure or diabetes where you could get a study with, 50,000 people, who have this condition. It's a lot of times these are smaller studies, particularly for the surgery, because as we mentioned, it's only a smaller percentage of people who go for the surgery. So the main thing I would suggest is if you really have tried all of the non-surgical approaches and they have not been able to give adequate relief, and someone really needs the surgery, certainly to speak with your surgeon, see how much experience they have with doing these particular surgeries, and what approach that they plan to use. For that area. One of the questions that I had in advance was along a similar lines, asking about the periosteum and about prolapse after surgery. Prolapse is when there's that sagging of the pelvic floor. If you think about the pelvic floor as being the things that, the pelvic, there's an opening, of course, at the base of the pelvic floor, but when we stand up, our pelvic organs don't just fall down onto the floor because we have those muscles and tendons and ligaments of the pelvic floor that hold them in place. And in that regard, there's sort of like a hammock or sling. And in the front of the pelvis, a number of those muscles and tendons attached to the pubic bones. And at the back of the pelvis, if you think about a hammock has to hook onto something. Well, many of those hook on or attach to the coccyx at the back. So if that coccyx is removed, you're losing some of the support system for the pelvic floor. So there may be this sagging or drooping or prolapse, as it's called medically, of the pelvic floor afterwards. So more common in women, and women are more prone to pelvic floor prolapse in the first place. So it's something to watch for. Unfortunately, I have seen a number of patients who, after coccygectomy, have had prolapse of the rectum, where the rectum now moves out of its normal position and back into the space where the coccyx used to be, and that can be very problematic and can sometimes require surgery to repair or to hold that back in place.
Right, next, somebody's having a coccygectomy early next year, and they were wondering what is the chance of possible symptom improvement and any tips after the surgery.
Sure. So the question is up, and we have hello from Holland too, which is great. I actually gave some lectures on coccyx pain in Holland in June of 2018 at the International Coccyx Pain Symposium. So anyway, back to this question, which is about somebody who's having a coccygectomy and they want to know about
what is the
symptoms that might persist afterwards. The main thing I would say for any medical procedure is to go into it with realistic expectations. So I would be cautious about thinking of it in sometimes physicians even may oversimplify things and say, well, you have tailbone pain, we'll chop off the coccyx, and then since the coccyx is gone, you'll have no pain anymore. And it would be fantastic if that was, always the case. And in fact, it's usually not the case. So the reasons, and this was another one of the questions that have been submitted in advance, which is, what are the reasons why people get pain that persists despite coccygectomy? And someone else asked here that as well, that even after the surgery, there's scar tissue in the area, which can be painful. There are sometimes retained bony fragments, which can be painful. There can be a seroma or a fluid collection in the area, which can cause pressure and can be painful. There are other things where the surgery is done. The nerves that were innervating that area, of course, would be cut at the time of the surgery, and the cut ends of the nerves can sometimes still be throbbing and painful. So you would feel that as pain coming from the coccyx, even though the coccyx is not there. Just like we see after somebody has an amputation of their leg, they'll say, "Doctor, intellectually, I know that my leg is not there. I'm not, imagining it or whatever, but I feel this pain it feels to me like pain in my foot, even though I know my foot is not there." Sometimes that is referred to as phantom limb pain or phantom limb sensations. So those are some of the things that can happen. The main things I would say in terms of watching out for that, the main thing is to keep in close contact with your treating physicians. Number one, avoid the surgery if you can, if non-surgical things are able to give you relief, which they are for the vast majority of patients. But if you really do need the surgery, first of all, make sure that it's a surgeon that has done a substantial number of these. Coccygectomy surgeries are not very common. Many surgeons don't do these procedures at all, or only very, very rarely. It was actually another one of the questions that was submitted in advance was along those lines of how come surgeons want to avoid this. Part of the reason they want to avoid it is that there's a high infection rate because it's so close to the anus. There's no way to keep the surgical site clean for as long as you could, or as well as you could if this was surgery on your wrist or foot or ankle or elbow. And that a significant number of these patients end up needing to go back to the operating room to clean out infected tissue. Surgeons, what they want is to, in general, go in and fix something and have it stay fixed and have that patient, have that surgery, have a great outcome, do well, and then, move on and do the same for the next patient so that they can make a positive difference for each of them. So the tailbone doesn't fall into that nice, neat category because often it's, you'll go in and do the surgery, but most patients are not 100% symptom-free by any means after the surgery. Many of them need repeat surgery because of either retained fragment or infection or other things. So that can be part of the reason why surgeons are reluctant to do these, or they just never had training because it's a relatively uncommon procedure that maybe during their residency and fellowship they never saw coccygectomy performed, or they only saw one, but they've been out in practice now for 10 or 20 or 30 years, and the last time they saw one was back in their training decades ago.
Right. Next, we have a person wondering if it's just a muscular problem, can we cure it?
Okay, great. So the question is, how about if it's a muscular problem and can that be cured? By muscular problem, really in this area, we're referring to the pelvic floor. And absolutely, there is somewhat of a chicken and the egg phenomenon that I just actually had this conversation with a patient earlier today about problems at the coccyx causing pain within the pelvic floor muscles, and problems at the pelvic floor muscles causing pain within the coccyx. And it really can go back and forth because those pelvic floor muscles and tendons and ligaments, as we mentioned, attach to the coccyx, a number of them. And people can have pain or other, regardless whether it's arthritis, bone spur, instability, fracture, dislocation at the coccyx. And what that can cause is spasm and guarding of the pelvic floor. So, for example, if I fractured my wrist, I would start to go into this guarding mode, and the next thing, my muscles in my upper arm and shoulder and neck region could be very painful and spasmed because of the problem that was down at my wrist. Similarly, a problem at the coccyx can cause pain and spasm, within the pelvic floor. But it also goes in reverse too. So patients can have a pelvic floor problem, and because of that spasm and tension and tightness and pulling, and all of that is those attachments pulling onto the coccyx, can start to create pain at the coccyx as well. So sometimes it is a matter of figuring out which one came first by history, or which one seems to be the most involved based on the history and physical examination, and addressing each of those either separately or in combination. And if there's pelvic floor problems, certainly a good pelvic floor physical therapist can be worth their weight in gold. They can be extremely helpful for a lot of those muscular components throughout the pelvic floor, and evaluating, just like if I had tightness in my shoulder area and my trapezius muscles, that there are things where that a good physical therapist can help with stretching and relaxation of those muscles, or if muscles are weak, to help to strengthen those. Those same principles really apply in the pelvic floor, just that the issue is that only a small percentage of physical therapists actually are trained or specialize in treating problems specifically at the pelvic floor, so in that pelvic floor region. So it's important to find a physical therapist if you have pelvic floor problems, to find a physical therapist who has specific training or expertise in pelvic floor issues, and they can be very, very helpful. I work with many of them from around the country, either in lectures and conferences, or in patients that we have in common.
Right, so next patient, they broke their coccyx about 7 months ago. It still has not healed. What should they do?
Okay, so the question is someone who says they broke their coccyx about 7 months ago, still painful, so what should they do? So first of all, the question is, did they really break or fracture the coccyx? And I would say that probably about 9 times out of 10, when patients come to be seen here at the Coccyx Pain Center or Tailbone Pain Center, and they say that they had a fractured coccyx, 9 times out of 10, they did not. So I'll show you what happens here, is that patients are told that they have a fracture because people see the joint line at the coccyx. So for example, I'll show you a picture of a dislocation, and I'll explain why I'm showing the dislocation picture in the answer to the question that's about the fracture. So basically here, you can see with the dislocation, the bones are intact, but the joint space in between the bones has been shifted. So that's a dislocation. It is very, very common that physicians in the emergency room, they may have an x-ray done that looks at the coccyx, and the physician will see the joint line and think, oh, well, it's called a tailbone, which sounds like it's singular, so they'll think that there should be just one single bone there with no joint lines, and they'll say, oh, well, that lucency, that line, must represent a fracture, when really it's not a fracture, it's just the normal joint line. On the other hand, a fracture, which I'll show you an image of that, is when there's disruption of the bone itself. Think about like a crack in the bone. So the comparison that I sometimes make is that if we were back in preschool and playing with blocks, and we were making a tower where we were stacking blocks, one on top of the other, a fracture would be if you broke the block, or if these were bricks, if you cracked the brick, that would be the equivalent of a fracture. On the other hand, if this is shifted, but the individual blocks are still intact, then it's not a fracture, then that's a dislocation. So first question is, was it truly a fracture, or was it a dislocation? And again, I would say probably 9 times out of 10, it's more likely that it was a dislocation or an unstable joint. And many patients will get improvement over time, just with things like using a coccyx cushion or things of that nature. But if the pain has been present for more than 2 months, then by definition it becomes chronic. It becomes called chronic coccydynia or chronic tailbone pain. And in those instances, it's really important to seek out medical attention from a physician who has expertise in treating tailbone pain, so that you can get an accurate diagnosis, so you can get the sitting versus standing x-rays to see whether there's instability there, which may be the reason why the pain is so persistent, and then to see about what the best treatments would be.
All right, next we have a person who's wondering, her coccyx moves side to side instead of the front to back.
Yes.
And she's wondering if, that would be captured on a sit-stand x-ray.
Yes.
And she would consider surgery.
Sure, yes. So yes, this great question. I think this was something similar that was submitted in advance as well. So basically, the question is, when we look at the sitting versus standing x-rays, and again, they can be very, very helpful at showing that hypermobility or excessive movement. And again, I'll show the image for that. So on the one side here, showing normal alignment when the patient is standing up, and then abnormal when they're sitting. But the question really is in not just when the tailbone, here I'm holding it up to kind of look from the side view, when the dislocation is not going forwards or backwards, which that side view would show sort of in the silhouette kind of appearance here. But what about if the dislocation is going from side to side? The way that sitting versus standing x-rays are done does not give a great evaluation for that side-to-side motion, and that sort of comes down to technical factors about the way that the way that the radiology equipment needs to be positioned. You can position it appropriately to get this clear side view, but when you try to get the view from looking from the front. Number one, the pubic bone can be in the way. You can accommodate for that by tilting, as you can see here. But even then, the view can be somewhat obstructed or obscured because in front of the coccyx, there's the urinary bladder up in the front of the pelvis, and then closer to the coccyx, there's the rectum, which has stool and gas. So that's collecting before you have a bowel movement there. So that blocks the view. So, and then particularly when you're trying to do that for a sitting X-ray, technically it can be very challenging. So to your point, yes, the standard sitting versus standing X-rays are fantastic already with the way that they are done, help to reveal the cause of the tailbone pain in the majority of patients. But there is that one group of people with hypermobility that the current sit-stand X-rays will miss, which is people where the dislocation goes from side to side. Now, that can be evaluated for on physical examination, either with external pressure or internally to see how much movement there is from side to side to some extent. Theoretically, this could be looked at also with a sitting MRI would be able to overcome some of the technical challenges with sitting X-rays. So that would be one possibility to look at as well.
All right, next, someone's just wondering if they can watch the live video later.
Someone's asking if you can watch the live video later. Yes, you can. So this will be on the website for the Tailbone Pain Center Facebook page. So facebook.com/Tailbone Pain Center. And this will be posted here today, November 15, 2019, for Tailbone Pain Awareness Day. So you'll be able to watch the whole video. Also on YouTube, my YouTube channel has dozens and dozens, several hours if you tallied them all up, videos all about tailbone pain. So lots of information there for you as well. That channel is called Tailbone Pain Doctor. So if you look for that channel on YouTube, you'll find that as well. And I have a playlist in there where, as I make new videos, I keep tacking them on. So literally, you could hit play, and while you're, washing the dishes or doing your errands or things, you could get some free education about tailbone pain. The book, as I mentioned, is available for free today on Amazon, and also there's a number of YouTube videos that I've done where I would spend 5 or 10 minutes just summarizing each chapter of the book, and I've gotten maybe a third of the way through it. So there's a whole series of those videos that are available as well, and it's on my to-do list to do the rest of them. But of course, busy with patient care and family and life as well. So,
all right. Next, we have somebody who's wondering if distorted sitting could affect their SI joint, and what could happen to the SI joint.
So the question is, can distorted sitting or abnormal sitting cause problems with the sacroiliac joint? And the answer is absolutely yes. I'm looking again for an image that I have in here, because many of these topics have, most of the topics that have come up, there's an individual chapter in the book about these. So for this is chapter 15, I think. Yep. So this talks about back and buttock pain in association with coccyx pain. And I'll show you an image here where some of the things that happen are that in association with coccyx pain, people start to sit abnormally. They start sitting leaning more towards one side than the other, or they start sitting leaning forwards, and then they start to get pain in a number of these other areas, in their facet joints, their sacroiliac joints, the piriformis, their ischial bursa. Sometimes they'll get symptoms down into the leg from piriformis syndrome. So there's a lot of other things that can start to become symptomatic if the tailbone is not treated and if you continue to sit in this abnormal position. So a lot of this is covered here again within the book. If you pick up your free copy today, it's in this is in chapter 15, and there's a whole section here specifically about the sacroiliac joint. And a lot of times I'll see patients who they have their tailbone problem. It causes them to sit abnormally, and then they get sacroiliac joint pain or facet joint pain, and they've seen their local pain management doctors, and they've had sacroiliac injections or facet injections, and the injections may help for a little while, but if the tailbone pain is left untreated and they're still sitting abnormally, then the pain just keeps coming back at the sacroiliac and facet joint or wherever else again and again, piriformis, etc. So it's really important to try to find what's the underlying primary pain generator that seems to be causing the other issues.
Right, next we have a person following up on one of the earlier comments. She had the MRI based off of our specifications in the book,
yep,
but it was all normal.
Sure. So somebody is saying that they have the book, that they looked at and must have spoken with their treating physicians to get the MRI orders done appropriately, but they were still normal. Now what? So the next question would be, well, that's great. The MRI can be very, very helpful at detecting certain abnormalities, but it still gets back to has the person had the sitting versus standing X-rays, which is really the starting point. MRIs are terrific tests, and they're high tech and expensive. But if I had to choose between the two, certainly I would go with a sitting standing X-ray over an MRI. As a diagnostic test for people with tailbone pain. So I would say probably if the MRI is normal, great. At least that it usually does a very good job of screening and making sure that there's no cancer, malignancies, cysts, tumors, those kinds of things. But it's important to see, well, have you had the sitting X-rays done to look for dynamic instability, an unstable joint? And also to look for bone spurs and other things that may or may not show up on the MRI, depending again on exactly how well it was done.
Next is also a follow-up comment. For synovial cysts, would you recommend a surgery or injection?
So the question is, for a synovial cyst, would you recommend surgery or injection? Probably as a starting point, I would probably start with a non-surgical approach first, in general. Often, within the book, the second half, again, is all about treatment, and it kind of follows a stepwise approach. And often with my patients, I discuss the treatment ladder. So starting with the simplest things first and climbing only to the next step if you need to. Or sometimes we'll talk about it being like a pyramid. At each level, there's a majority of patients who do well and do not need to sort of climb the next level to get more and more aggressive with their treatment. So typically I would say for most people, if they had a synovial cyst, at the coccyx, and they have not had, local injections and things of that nature. In my practice, certainly I would start with that as a non-surgical treatment before progressing to surgery. But of course, with the usual disclaimer that if I'm not your individual treating physician, this is not medical advice. So of course, discuss that topic with your in-person physician.
All right, next, what would be the long-term approach to a hypermobile coccyx caused by a fall?
So the question is, what's the long-term approach to a hypermobile coccyx caused by a fall? So with a hypermobile coccyx, the long-term approach really depends upon how are you responding to treatment. So for example, there'd be some people who may have some hypermobility where just by using a coccyx cushion, which again, there's a chapter in here specifically about, different cushions that can be used for coccyx pain. Wedge cushions, typically better than the donut cushions. But basically, there's some people where if they use a cushion and they avoid certain activities, so they avoid, things that make their pain worse, like horseback riding and cycling and rowing and a few things like that. That may be all they need. Other people may need to do things like, pelvic floor physical therapy. Other people may need to do things like local injections. Other people may need surgery. So it really depends on what things have been tried and how well have you responded. So for example, if a local injection that takes a few minutes gives 100% relief and the pain doesn't come back, for many, many months or even years and years, well then it might be that from time to time somebody has a repeat injection, and other people it may be that's not the solution, that they're not getting enough relief from that, and they may be in that 1% or so of people who end up actually needing surgical treatment.
Next, the patient was wondering, the fused tailbone that we just talked about, it cannot bend. So would you recommend surgery or still explore injections or other?
Sure. So the question is, would you recommend injections if the tailbone is fused? And again, it's a little bit of semantics, but just since we have a legal department here, they would probably want me to point out that I'm not recommending that you specifically have an injection or a surgery, but really, again, the point of this session, as I'm sure you understand, is educational. So I'll take your question and answer it in a general way. For people in general who have a fused coccyx, it does not follow that just because the tailbone is completely fused, or because it's hypermobile, or because it was fractured, or because there's arthritis, or because there's a spur, that automatically that means you need surgery. No, the vast majority of all of those patients will respond well to non-surgical treatment. The only things where I say, patients really need to go promptly for surgery are for some of the cancers or malignancies that happen at the coccyx. Again, there is a chapter on that within the book. It's chapter 13, which is all about cancer causing tailbone pain. Chordoma is a terrible malignancy. It has a tendency to occur at the sacrum and coccyx, and unfortunately is usually fatal, even with surgery in the majority of patients. And I have had a number of patients, unfortunately, over the years now, just having treated so many thousands of people with coccyx problems. I've had a number who we've diagnosed with chordoma, and in those patients, absolutely, they need to get to the operating room with a skilled surgeon as promptly as possible to remove the cancer or malignancy before it spreads. But in the vast majority of other patients, including those with a fused coccyx and including those with a hypermobile coccyx or arthritis or dislocation or fracture or spur, most of them will do well with non-surgical treatment.
The next person is wondering, will a physical pelvic therapist help, and would it feels great in the moment, but the relief does not last?
Sure. So somebody's saying that the pelvic floor physical therapy for them feels great in the moment, but does not last. So basically, again, it comes down to what's the specific diagnosis that's being treated, and is there an underlying problem at the coccyx? Let's say a bone spur, for example, would be a common example, or hypermobility, and that the spasms within the pelvic floor that the physical therapist is helping with are really just secondary to the underlying pain generator at the coccyx. In those instances, you would not be surprised that the problem at the tailbone, being persistent, causes the spasms of the pain within the pelvic floor to continue to recur. So it feels a little bit better while the pelvic floor PT is working on it, but then it may not last. So again, in some patients, the relief from pelvic floor PT absolutely can last, and again, a good pelvic floor PT, as I say, can be worth their weight in gold. But in instances where it's not doing the job, or you're not getting the sustained relief, then it makes sense to to look further, or to look at other options, and to consider other treatments. Okay.
Next, the patient's wondering if you had any advice after coccygectomy for recovery.
So advice for after coccygectomy for recovery. So the main thing, number one, certainly keep in close contact with your treating surgeon if there's any questions or concerns in the area. It's important to keep a close eye on the skin. Wound recovery, wound healing and wound recovery at that site are really problematic for people who have undergone coccygectomy surgery. So what you want to do is keep an eye if the skin is starting to open up again after it's been healing, or starts to get red or infected, or increased discharge. You want to see your treating surgeon sooner rather than later. It's not something to just wait on. Also, make sure to follow your surgeon's recommendations regarding how soon you should be sitting after the surgery. Many surgeons will say that after coccyx, amputation surgery, coccygectomy, not to sit for at least a good 6 to 8 weeks. So during that time, people will eat standing up at the kitchen counter. If you're watching TV, you're laying sideways on the couch. If you're on your computer, you're either at a standing workstation or standing up at your countertop, or lying on your chest on the carpet or on your bed while you're on your laptop, for example. So giving that area a chance to heal is absolutely crucial. And then, even before that, again, as I mentioned earlier, to make sure that you're treating with a surgeon who's familiar with, and has experience with performing the procedure.
Your thoughts on sit to stand, pain with sit to stand, and especially when getting out of the car?
Great. So this question is, what about the coccyx pain when somebody is going from sitting to standing? So classically, we think of tailbone pain as occurring when somebody is sitting down, and especially sitting leaning partway back, because as we mentioned, while you're sitting down, you're basically putting that pressure onto the tailbone or coccyx. But with that hypermobility that we talked about earlier, where sitting causes that dislocation or partial dislocation at the joint, what can happen is that when somebody goes then from standing to sitting, they put their body weight onto it. Their coccyx goes into that hypermobile or dislocating type of position, and that's painful for them. But then when they stand up, the tailbone can sort of snap or move back into its normal neutral position, and that is often can be even more painful. So there was one study that looked at this, again done in Paris, France, that found that patients who had pain with sit to stand had a higher likelihood that they have hypermobility for the reasons that I just explained. Similarly, if somebody had a dislocated shoulder, it's very painful while it's dislocated, but in the emergency room here, I'm at a level 1 trauma center, if we were to pop it back into place, so to speak, during those few seconds while we're relocating the shoulder, that was dislocated, there's increased pain as it moves abruptly back into that normal position. So the same type of thing can happen at the tailbone. It's a great question. And certainly, although I would recommend that anyone who has chronic tailbone pain, meaning pain that's been more than 2 months, persistent, should have sitting versus standing x-rays. That is even all the more true for people that have pain that's with when they're going from sitting to standing.
All right, next somebody's wondering if you're familiar with any cases of extended surgical cases causing post-operative tailbone pain.
So the question is, are there extended surgical cases causing post-op tailbone pain? So if you're saying causing tailbone pain, I'm assuming that the person had no tailbone pain prior to the surgery.
Yeah.
Absolutely. So unfortunately, I've seen a number of patients, unfortunate meaning for the patients, of course, that they have no tailbone pain. They go in for some surgical procedure, and then after the surgery, they have pain. And there's a number of reasons why this can occur. Sometimes it is a matter of how the person is positioned during the surgery, that they may not have a lot of padding, under their tailbone. So their tailbone may have been pressing onto the operating room table in a certain way for hours on end. If it was particularly with a long surgery, the person would be under general anesthesia, so they can't feel that they're having all of that pressure there. So that's number one. Also, when people are after their surgery and they're sitting in the hospital bed, most hospital beds, if you think about it, they're sort of on this angle. So that as you're sitting in the hospital bed, you're basically doing the equivalent of sitting leaning partway back, which is the most painful position for most people with tailbone pain. So often there can be things that mechanically are happening at the tailbone in association with either the time in the operating room or the time that you're sitting in hospital beds and such during your recovery period. Now, there are a few other things, though, that the dura mater, which is basically, if you think about it, it's the lining within the spinal canal that holds in the spinal fluid, and the spinal cord is inside of there. That lining of the spinal canal, which basically lines, it's lining inside of our skull to hold in our cerebrospinal fluid, and all the way down through the spinal canal, has attachments down at the tailbone. So I have seen a number of patients who've had surgery at their cervical spine, at their neck region, did not have any tailbone problems beforehand, but after the surgery that they've had up at their neck, they have ended up with problems down at the tailbone. Part of the thought can be that there may be some pulling or tugging either during the surgery or from scar tissue during healing from the surgery that is pulling on that lining, which again is down at its far end, anchored or attached down to the coccyx. So that can be an issue sometimes.
Right. Next, somebody's wondering if it's possible to get the literature for the sitting x-rays.
Sure. So the literature for the sitting x-rays, yes, if you, I will try, probably easiest is, I'll try to circle back through this, probably through this weekend, and post some links down below, within this, so that I can drop the link in to get you some information, some of the publications and things on that. You can find that on PubMed, by the way. If you go to in the United States, the National Library of Medicine, which is part of the National Institute of Health, has a website called PubMed, PUBMED. And that's sort of a repository of at least the listings and the abstracts for, probably hundreds of thousands of medical journal articles. And if you were to put in the primary author for most of those, would be last name would be Maine. It's Maigne. And if you put in Maine and the word Coccyx and the word dynamic, it will pull up a couple of Dr. Maine's articles that explain this very, very clearly. So, great question.
Your thoughts on prolotherapy?
Great. So the question is about prolotherapy. The idea of prolotherapy is a little different than, it's sort of the opposite of putting a local anti-inflammatory to quiet down the inflammation. The idea of prolotherapy is maybe what you want to do is actually, sort of jumpstart the immune system and cause some local inflammation and therefore scarring and those kinds of things in the area. And I think that there's some potential role for prolotherapy for certain subpopulations of people with coccyx pain. I would not expect it to work, for example, with somebody who had perhaps a bone spur or something of that nature. But for some of the hypermobility patients, there may be some potential role. It has not been well studied, but I would say it's not a crazy idea, and it is something that that may be worth considering.
Right. And what is the incidence of coccydynia, and would you consider it rare?
So it's a great question. There's in terms of what's the specific incidence and would you consider coccydynia to be rare? All of these things become relative. So there's not great data on that, and there's a number of reasons for that. Number one is because it tends within, the way that a lot of times we look for this kind of data is we look at what diagnosis code is used by the emergency room physician or the orthopedic or pain management or primary care doctor when they're submitting their insurance paperwork on a given patient visit. And a lot of times, as I've mentioned, these things get labeled as being low back pain. So it sort of falls off the radar in that regard. So again, I would say probably it is 10 to 20,000 times less common than low back pain in the lumbar region. But with more than 7 billion humans on the planet, something that happens only, let's say if it's happening only 1 out of 10,000, that still means that there's lots and lots and lots of people that are suffering with this, just that they don't tend to be all in one area. So at the Tailbone Pain Center here, for example, more than half of our patients come in from out of state. About a third of our patients actually fly in to see us. And that's only because they have a condition that's rare enough that they cannot find a local physician who's experienced at treating this. So many musculoskeletal or pain docs, or certainly primary care doctors, may see thousands of patients with other conditions before they come across someone with a tailbone problem. So whether you label that as rare, I would say, yeah, it's certainly much less common than lots of other musculoskeletal conditions. Certainly dramatically less common than low back pain in the lumbar spine or arthritis in the knee or carpal tunnel syndrome or things of that nature. And yet still, we see thousands of patients because people are suffering and not able to get relief. So I had a medical student here who was rotating about a year and a half to 2 years ago, and on the first day of the rotation, after a couple of hours, through seeing patients through the morning, he said, "Wow, I never knew that tailbone pain is so common. It seems like almost every patient has tailbone pain." And I said, "Well, that's because we're a Tailbone Pain Center," and he had not realized. He was thinking like, "Oh, that's the most common musculoskeletal condition that people go in to see a musculoskeletal or pain specialist for." But that's really only true if you're at a Tailbone Pain Center, I guess.
Right. Your thoughts on the correlation between enlarged prostate and causing coccydynia?
Sure. So the question is there a correlation between enlarged prostate and causing coccydynia? Not that I know of, and I really would not expect there to be a direct correlation. The prostate and the urinary bladder are up at the front of the pelvis. The coccyx is at the back of the pelvis. The one important exception to that certainly would be with prostate cancer. So people who have prostate cancer and other pelvic cancers, whether that's for prostate, of course, for males, or for females, cancer of the uterus or cervix or ovaries, those pelvic cancers can spread from their originating site, and sometimes they spread to the sacrum and coccyx and can cause pain in those areas. With those kinds of pelvic cancers, certainly they can cause tailbone problems. But an enlarged prostate in and of itself, I would not expect to be causing problems at the tailbone.
Do you think an injection into the muscles would be helpful?
Do I think an injection into the muscles would be helpful? It really depends on what's going on and what type of injection we're talking about. So, for example, lots of people with coccyx problems will have piriformis muscle pain throughout the buttocks, and certainly putting an anti-inflammatory at the piriformis muscle can be very, very helpful for many, many patients. There's sometimes with in a much smaller percentage where people have persistent pain in some of those muscles, where injections of botulinum toxin, things like Botox, can be helpful. So certainly there's a lot of muscular injections that can be helpful for muscular pain. But on the flip side, if it was a dislocating joint, then that was the sole or primary source of the pain, then I would not expect the muscle injection to make such a big difference. So we may do just one or two more questions, because I do have some patients shortly coming back in the schedule this afternoon. So
sounds good. Your thoughts on coccydynia and sexual function/dysfunction?
Sure. So the question is about coccydynia and sexual function or dysfunction. So a couple of things I would say here, especially if the pelvic floor is involved, it is very common for people with pelvic floor dysfunction to have sexual dysfunction. So for women, for example, they may have painful intercourse because of spasm throughout the muscles, spasm and pain throughout the muscles of the pelvic floor. Pain in general, even aside from pelvic floor issues, pain in general, even if it was migraines or if it was a shoulder rotator cuff, when people are in pain, they tend, of course, to be in a different state of mind psychologically, and that can certainly affect sexual interactions, whether from initiation to performance issues and interpersonal stress. When somebody has pain, it changes a lot of times the dynamic within the relationship. Pain and other disabilities, disabling conditions can do that. So it really depends on the specifics for an individual patient.
At what point should I give up on the ganglion impart blocks? So
at what point should you give up on injections, we'll say in general even? It really depends upon the response, and which I typically measure based on what percent relief did it provide and how well sustained was that over time. So whether to give up on any given injection or other treatment really depends upon how well has it been working for you. So, for example, if someone says, boy, my tailbone only bothers me when I do a long flight and I bring my cushion along and that does the job for me, so I'm okay. At what point should I give up the cushion and sort of climb the next rung up the ladder? It really depends. If it's not too big of a hassle to bring the cushion and as you take your flight, then continue to do that, and maybe you don't need any injections. If the injections are providing excellent, let's say 95% to 100% relief, and that lasts for a year, 2 years, 3 years, then I would say, oh, that's a good response. I would continue to repeat that, on that occasional basis, on an ongoing basis. Someone may need an injection every year or two, or maybe once or twice a year. There's other factors that come into play, of course, geographically. As I mentioned, a large percentage of our patients fly in from around the country. So having an injection, let's say every 6 to 10 or 12 or 18 months, maybe a reasonable option if it's not too big of a hassle to get to your physician for treatment. I've had patients in the last year from New Zealand and from India and from Sweden and South Africa, and so obviously for those kinds of folks who are coming from literally around the world, coming back for an injection every 10 months really is not the most optimal answer, and some of those patients may be looking to see, well, are they a candidate for moving from ganglion impart injections to the next level up, which is typically nerve ablation, which is where we kill or deaden the nerve fibers, or in a smaller percentage of patients to move on to considering surgical removal. I think maybe we'll do this just because I know it is almost 3:30 now here in New Jersey, and I know that I do have a 3:30 patient scheduled. So I'm going to make sure that that I want to be on time for them. So we've been on for I don't know, a little over an hour and 20 minutes or so. This video will be available here on the Tailbone Pain Center website. We also may try this year to take the video and to splice it into smaller segments answering the specific questions so that I can maybe put those on YouTube and make it easier for somebody who only wants to go to find a specific answer. Also, I would recommend for those of you who do not yet have a copy of the book, Tailbone Pain Relief Now, you can get that for free today on Amazon on November 15, 2019. And I may be able to extend that, but I would say definitely grab it today to make sure. You can get the electronic copy, the ebook copy, or if you already have a copy of the paperback book, get a free copy of the ebook version so you have that as well. Or if you have family, friends, your spouse, your physician, your physical therapist, what have you, that you want to share information about tailbone pain. As many people as want to grab it for free, the more the better, to really spread the information about this. I've really enjoyed talking with all of you. I appreciate all of the phenomenal questions. I did get a lot more questions than I could really answer in the almost hour and a half that we've been going. But I will do my best to circle back and either in subsequent videos address those, or perhaps post some links in response to some of those questions on the Facebook page to where you can find more information on those topics. If you're looking for more information in general, go to tailbonedoctor.com and specifically there's a blog there. So tailbonedoctor.com/blog, and there's a search box there. So if you have some specific question, whether it's about impar injections, ablation, surgery, cysts, pilonidal cysts, Tarlov cysts, coccygectomies, bone spurs, you name it, there are hundreds and hundreds of articles on there all about tailbone pain. Or for if you prefer learning and getting education from video on YouTube, go to my YouTube channel, which is Tailbone Pain Doctor, and there's lots of information on there as well. So wishing you all the best for the second annual Tailbone Pain Awareness Day. Hopefully it's been a good opportunity to bring attention and education around this issue, both for people that are suffering and for healthcare providers. So thank you all for being here, and I wish you all the best. Bye-bye now.